Nalini Kaushik, and on behalf of the Integrated Health and Wellbeing Council, which is India's premier institution for health awareness, advocacy, and behavior change, I welcome you all for joining us today. Today, we are graced by the presence of the esteemed Honorable Governor of Telangana and the Governor of Puducherry, Dr. Tamilisai Soundararajan. A very warm welcome to you, ma'am. And before we proceed with the program, I request everyone to please stand up for the national anthem.
Jana Gana Mana Adhinayaka Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladhi Taranga तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, everyone. Dear ma'am, with due respect, I would request your permission to start today's program.
Yeah, permitted.
Thank you, ma'am. So, snake bites. For people living in the cemented societies and cities, snake bite is mainly a scientific research domain, or an unfortunate event that they no longer even see in the films in today's time. However, India's realities are actually very different. In last 20 years, if we look at the period from the year 2000 to 2019, the country has recorded a staggering 1.2 million snake bite deaths, with an average of 58,000 deaths happening every year, and India is at the peak of it. In fact, as much as 97% of these deaths that happen, they happen in the villages, and more than half of the dead are men in their most productive life years. And there's no wonder, in fact, that majority of these deaths are said to happen due to poor availability of right or enough antivenoms with the healthcare providers, or out of facility deaths, many a times they even remain out of the ambit of the official records, in fact. And in fact, it won't be wrong to say that the World Health Organization, the addition of snake bites and the resultant envenoming to the priority list of the neglected tropical diseases is the need of the hour. So therefore, with these large number of deaths that are happening due to snake bites, lack of availability of timely treatment, poor awareness amongst people as to how they can even prevent being attacked by a snake, it indicates the need of an all-encompassing, large-scale, ground-level campaign to save people and to help India to tread on the path of development. And as a starter towards the same ambition that we have, we are joined today by an esteemed panel of healthcare experts, doctors, policymakers, and administrators who will show us the right way to the end. And most remarkably, we have with us the Honorable Dr. Srimati Tamilisai Soundararajan. Wearing multiple hats of serving the people and dedicated towards the public health, Dr. Tamilisai is also a gynecologist and has received a special training in sonology and FET therapy in Canada. With this, I really want to thank the Honorable Governor for sparing her valuable time to support a health issue that definitely needs its due recognition and importance. And I would request you, madam, to address the gathering and set the context for today's discussion. Ma'am, over to you.
Very special good afternoon to each and everyone. I apologize because I had a Sainik welfare meeting and I was unable to join you in the correct time. Please do I apologize for that. And my respects to Mr. Kamal Narayanan, CEO, Integrated Health and Wellbeing Council, Mr. Vishwanath Swaroop, COO, Bharat Serums and Vaccine Limited, Dr. Vinita Srivatsava, Advisor, Tribal Health Cell, Ministry of Tribal Affairs, Dr. Hira Lal, IAS, Additional Health Mission Director, Government of Uttar Pradesh, and Ms. Urvashi Prasad, Director Development Monitoring and Evaluation Office, Niti Ayog, and Dr. Soumya Deep Bahumik, Co-Head, Meta Research and Evidence Synthesis Unit, and the George Institute for Global Health India. I'm sorry if I would have pronounced in a wrong way, because this we are used to the South Indian names. Dr. Priyanka Kadam, President, Founder, Snakebite Healing and the Education Society. Mr. Vivekananda Mishra, Vice President, Integrated Health and Wellbeing Council, and all other dignitaries and other participants. And Dr. Nalini Kaushik, the Principal Consultant, Policy and Advocacy and Government Affairs.
Thank you, ma'am.
Council. A special good afternoon to each and everyone. And this snake bite, this topic, and I should appreciate the Integrated Health and Wellbeing Council for organizing such a very important program with such a very important topic. This subject is very nearer to my heart because I had my undergraduate studies, that is MBBS, from a peripheral, remote village medical college. Even though I joined as a Madras Medical College student, after my marriage, I was shifted to Tanjavur Medical College, and that medical college surrounded by fields. No day will be there without a snakebite case. The casualty, no day during our studentship and during my house surgeonship, have not faced a single day without a snakebite case, because it's an agricultural district, and even that medical college, in the medical college itself, students will be admitted with snake bites, because it was a mango grew and cashew nut tree grew, and the college was situated in a field, a 100 acres field. One of a kind-hearted person donated 100 acres fields at that time, and it was constructed, and totally it was dealing with the people who are involved in agriculture and farmers. And I feel that even now it's alarming situation that the number of snakebite cases have been increased, and the way we are facing the problem, and the inadequacy of the expected amount of antivenom therapy, and the experience and practice in using it, this all should be thought in a wider prospect, because snakebite cases is highly preventable, and awareness should be created among the people. And if good awareness created, because it's not that all snakes are poisonous, so the people, sometimes I have seen patients, non-poisonous patient, bite by non-poisonous snakes, but died because of shock.
Yeah.
Seeing a snake. So that awareness, that snake bite patient could be saved, and that message should reach each and everyone. And some small precautions. For example, we cannot, in a country like us, we cannot ask everyone to go with the boots or a covered shoes, but they should be aware of the situation where, particularly, for example, if it's a rainy season, all the snakes will be washed into the pits. So most probably walking in the rainwater itself is dangerous than when we face the other conditions. So such things, always cautious about the snake bite condition, about the presence of the snakes. And some small procedures, for example, having a lamp in the entrance, having the lamp in the corners, and such precautions could be taken in the village houses and the villages. So such awareness should be there. And apart from that, treatment wise, as a medical student, I have seen, because my husband is a nephrologist, and we have seen viper bites with acute renal failure, acute renal shutdown. We cannot comment on cobra bites, because highly it's neurological, neurotoxic. But we have seen patients with coagulation disorders and with neural involvement, when patients come with viper bites. So only we always say, please identify the snakes bitten by them. Some patients will even bring the snakes in villages, they will bring the snakes, and sometimes I have seen cases when they when they bring the snakes, that during catching the snake itself, they have acquired the poison. So that also should be highlighted to them. So because even a dead snake, if that through the teeth they can get the poison. So this awareness, and I have seen patients with coagulopathy and with acute dialysis, because it's a peripheral hospital without hemodialysis machines, and we have organized acute peritoneal dialysis in side rooms, and he has saved so many patients. So according to me, this snake bite antivenom should be available in most of the peripheral centers, particularly the village centers, and particularly during the night time, because most of the snake bites are from evening to 10 p.m., 5 p.m. to 10 p.m. So that preference should be there, and there should be expertise in administering the antivenom, because for all antivenoms cannot be given. Antivenom should be given when there is coagulopathy and there is neurological symptoms, and allergic conditions due to antivenom also should be treated. That should be a good protocol. And according to me, because antivenom, this protocol, we are following almost the WHO standard, and which is followed by the foreign countries. Each and every village and our country, and even regionalized, they should have a different protocol. We have to work in a wider way like that, because we want to save the patients. Most of the patients, it's highly preventable, and there are some old practice like tying a tight tourniquet, then releasing it immediately, the poison will reach the circulation, and that itself then immobilizing the we must ask them to calm down, immobilizing the bitten area, and lowering the limb than our cardiac region, so that it will prevent the circulation than tying a tourniquet. So small things, these type of, then immediately reaching a hospital, then slitting, sucking, and tying, these type of delaying it. So these type, everything should be highlighted to them, and that awareness should be created, so that the people are aware of the situation. So this I take this opportunity to convey my message as a practitioner and as a young medical graduate who has seen large number of snake bites, or large number of acute renal failure due to snake bites, and panic death due to snake bites. And I remember one boy who actually put his hand in a pit and was repeatedly bitten by a snake, and then we treated that patient, and I should say my husband has even transplanted a snake bitten boy died because of snake bite. So such things also happen. So one thing is awareness about the snake bite, and small things which can prevent the snake. Because for example, sleeping habits of the village people, they should not lie down, and it is said that the snake will follow the rat, and because of the rat will jump on the farmer, and because of that he gets the bite. So he should, even that mosquito nets prevents them from mosquitoes as well as from snakes, they are telling that. These are small things which can be carried out, and having a light with them when they go into the fields in the night time, having a light, and having lamps in the village houses, in the corners, in the entrances, and having having a clear path, and not sleeping in the places where things are stored, because high incidence of snake bites in that areas. So first awareness should be created, and medical facilities, particularly in the village areas, and particularly transport should be there. If a snake bite is identified, ambulance facility should be there to take them to the tertiary centers, and availability of the anti-snake venom, and high trained staff to administer the anti-snake venom, and dialysis centers to treat acute renal failures, and all these things should be thought of. And I think you're all expert heads, and you would have discussed all about that. But what I thought I wanted to express, and I'm really very happy that this for this awareness you're conducting this program. And such things with meticulous planning and creating awareness among the people really will prevent the snake bites. And we have to reduce the number of snake bites, and we have to improve the livelihood of the farmers, and we have to reduce the morbidity and mortality due to snake bite. And with all our improvement, and because of our honorable prime minister, now he has implemented the Ayushman Bharat insurance scheme, and there are more number of medical colleges in the district. So these all will help us to prevent snake bite deaths. But anyhow, thank you very much for organizing this program. Creating awareness is the need of the hour, and treating them in the peripheral hospitals, and making availability of the anti-snake venom and other special treatments for snake bites. I think that should be available. Thank you so much.
Thank you so much, Honorable Governor Madam, for setting the context so beautifully for us, and also, really giving us the ground reality. And now I would like to invite Mr. Vishwanath Swaroop to, give a vote of thanks to Honorable Madam.
Thank you, ma'am. This is an honor to be on this panel. And what you just shared from your personal experience is very, very helpful for us. Let me first start by congratulating you as well as the entire infrastructure and all our healthcare workers. Yesterday, as a country, we have vaccinated the population of Australia. And I, as an Indian, feel very, very extremely proud of this moment, right? We can say 2.5 crores, but when you think of the dimension of this, we have vaccinated an entire country, a developed country's population. And ma'am, I thank you and the entire infrastructure who has helped us achieve this. Having you on this platform, madam, is a fantastic opportunity, and your experience that you have brought in was very, very helpful for us. And what you've talked about is starting from prevention, talking about awareness, and then treatment. I think these are important areas for us to work. And what we were being talked about earlier was very, very clear. As a country, we are still facing about 60,000 deaths every year because of this. And that is why we are committed to this cause, madam. And if you do the math, it will come out to be about 150 people dying. Again, I repeat, 150 people dying because of a much preventable issue. And as a country, again, you brought up Ayushman Bharat. I think the government has done really well to include this treatment under Ayushman Bharat as well. So again, thank you for your time, madam. I know you have a very busy schedule, and having shared your personal experience in addition to the gravitas that you bring with this, I think it's just phenomenal for this cause, madam. And we are continuing to support this and be committed to this space. Thank you so much.
Thank you.
Thank you, Mr. Swaroop. And once again, I kindly request everyone to please stand up for the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you, ma'am. So that was the Honorable Governor of Telangana with us.
Thank you.
Thank you, ma'am. So Honorable Madam actually gave a very good glimpse of the diversity of the panelists and the other speakers that we have today. And the interest of time, I will start directly with our first panel discussion that we have scheduled today. And my first question, in fact, is now directed to Dr. Hira Lal, who is the Additional Health Mission Director of Government of Uttar Pradesh. So, very warm welcome and thank you for for the patience today. So, I would like to, because you represent a state government here for us, and also a policy maker in a way. So, I would like to start with the policy frameworks of India, because if you look at the government of India, it has already made like a significant progress when it comes to the issue of snake bites in the policy agenda, at least that the Ayushman Bharat scheme has a specific measures in place, and then also the treatment to be provisioned under the essential medicine schemes. However, there still exist some bigger challenges around this particular subject, and in a way, there are huge policy challenges in front of us. So, what do you think that under NHM and also otherwise, what can be done really to address this particular challenge in India?
Okay, thank you. First of all, I would like to thank you, your IHW team and Dr. Kaman Nayanji, who is the only person who is taking this snake bite issue as an event. I have not seen any other webinar on this issue. And I will thank this team that I have learned a lot since within 2 days about the snake biting, because I have to speak over here. So I start studying what is this thing. Though I have served as a administrator 25 years and I have encountered many problems due to snake bite. But this event invitation have made me to learn. So the basic 2-3 sentence I would like to say: snakes are friends, not foe. First sentence. Snakes are friends, not foe. But reality is that everybody thinks snakes are foe, not friends. So we will have to change this situation, that we must respect the snakes as friend, not as a foe. I'll get into details. Second thing, prevention is better than cure. So in the light of snake bite situation, or in the light of snake discussion or bite crisis, both cure and prevention, both are weak in this situation. In the case of cure, not reaching timely to the hospitals, not getting the timely medicines, and different reasons are there. So cure issue is also poor with respect to this issue. Second thing, prevention. I belong to villages. My grandfather used to say, if you go out, take a torch. Either take a bamboo lathi, which we say lathi, Gandhi ji ki lathi, leke go outside with Gandhi ji lathi, and keep tucking on the road, hitting on the road. So a noise will come, and if there will be any snake, they will go from the away. So from the prevention point of view, people are not aware. So we have to strengthen our prevention and cure both. Okay. Third thing, snake bite is the neglected public health crisis. But I am thanking you again. At least you are putting some light on this, and particularly myself, I have learned a lot. Actually, I am sitting, my office is in a 4th floor of pickup building, and on the 3rd floor there is a diversity board office. I sent on my official go and bring out the information what is the role of snakes in the biodiversity. From there I came to learn that snakes are friends, not foes. Okay, snakes maintain balance in the food web. Snakes are the natural form of pest controls. So there are so many things which is not known to even very learned people. So awareness, and this awareness particularly in rural areas, required to be done on a large scale. One more thing I would like to add, the 1926 is a helpline in the case of snake bite. Okay, People don't know this number 1926 is a number. If you see any snake, if there is an incident of snake bite, dial this number. You will forest department will come to help you to tackle such situation. But 1926 is unknown, even me unknown from this number. Okay. And third thing, I would like to tell my own experience that I was collector Bandha. There was a snake bite incident, 2 persons died. And when morning this information is spread in the nearby villages, there was a land order situation. And situation was so grave, I sent my SDMs, I sent my ADMs, and I sent my third layer CDO. People did not obeyed our request, and finally I had to, as a district magistrate, I had to reach there to convince them that I will give you the financial help. So this situation needs the attention of the public. So I will thank you, Dr. Nalini, Dr. Kamal and your team for bringing me on this forum. So this is my point on this issue. Thank you.
Thank you, Dr. Lal, and I think that was very informative. And thank you for really touching the root of the problem here, and highlighting that we really need to mainstream the issue, and prevention along with cure is the way to go on this particular matter. So here I would like to bring in Ms. Vinita Srivastava, who is the advisor at Ministry of Tribal Affairs, Government of India. Good afternoon, ma'am.
It was nice to hear everybody what said about. Can you hear me?
Yes, ma'am. Now we can.
Can you hear me?
Yes.
So it's a pleasure to be here and learn about these snake bites. And Honorable Governor has already said so much about the things which is very important in life, that the prevention and the management part both are important. So those things has to be kept in mind. And when we talk about tribal for snake bites and all, which is very important. While I was doing my blood disorders part, the coagulation part was very important, which we initiated a file in the ministry itself, I think 4 or 5 years back, where we said that this coagulation is important for getting these snake bites, to know what venomous is there and how much is the clotting is being done or how much the bleeding is being done, which is very important in our life. So the concern was, when I was talking about press, now this is important for us because while I was going through the data, which is a very small and a scanty data with us, which says about that the problems are existing and there is no management system at the peripheral level to take care of the things. Yeah. So now the task, and we say that now the time is that each and every different doctors, especially the physicians, need to learn, and the paramedic staffs need to learn management facilities. And we don't have such modules with us, which is very important. Because the problem is that the modules are still lacking. We need to have such management modules which is going to help the country where the snake bites are there. Regarding that, as my previous speakers has already talked about, that the snakes are friends. We understand that the snakes are friends. DIG Banda, I still remember, एक सिपाही को एक सांप ने काट दिया था, but he was saved very well because they know the medicinal plants at the center also. That was very interesting, that this tribal healing part also should be taken care when you are doing the awareness. We need to include a tribal healers which knows about the medicinal plants which are going to take care of these patients as well. Regarding the prevention, because all snakes are not venomous, that we understand, but still we need to learn about those who are venomous and who are not. So those things, that तभी कहा जाता है कि जब snake bite हो तो आप उसकी photo खींच लीजिए. So at least you are knowing what exactly it is. But I should say here that the time is here that we need to start a good prevention and awareness programs in the country where we can take up the issues in a larger aspect. Larger aspect, I said, that the prevention and management guidelines both are important. It is not only that we have to think about the prevention, we also have to think of the management at the peripheral. CSC अगर ये सुविधाएं नहीं होंगी तो हम उनका मैनेजमेंट नहीं कर पाएंगे. And we have to understand. So now the time is that we sensitize the people. We take up the issues at the morning. I have a meeting with the Honorable Minister also, and I have spoken about this program. And I told him, sir, take up these issues at the central and the state level where we have much high of the tribal populations because they are the sufferers. Maximum time they are the sufferers. अभी जैसे यूपी के जिलों की बात हुई, जैसे अभी हमारे पीछे जो एमडी हैं उन्होंने बात की, उन्होंने कहा कि बांदा में जो 2 केस हुए उसको मैनेज करना कितना मुश्किल था, बिकॉज ही वाज द पीपल एट द देयर. So now concern is and request to you all that we need to have a good experts across the country. I just had a small guidelines from Himachal yesterday. उमेश भारती जी ने उन्होंने भेजी मुझे, क्योंकि वो काफी चीजों में इन्वॉल्व रहते हैं, तो उन्होंने कल मुझे वो गाइडलाइंस भेजी, which was very interesting to learn. So such guidelines that has been meant for Himachal Pradesh. Now the time is that we should have such guidelines for the entire country as well. So these are my concerns, and the coagulation labs are important, which should be there at least in the district hospital and the CSC level also, because coagulation is not a big deal now.
Right. Absolutely. Yeah.
Lab should be coagulation lab should be established at the CSC level, which is very easy to do, and the training of these technicians that they take up this in a better way. So that is my concern of taking up the issues in a at the ministry and with the Ministry of Health, which we will take it very soon, because whatever guidelines Ministry of Tribal Affairs will prepare will also include Ministry of Health to take up simultaneously a better job in the coming future. Thank you so much.
Absolutely. Thank you so much, Ms. Vanita. And I think thank you really for giving us, this broad technical picture of the subject. And I think I see one coherence of message, which is, about the prevention, which Dr. Hiralal also spoke about, and even you, sort of pointed at that particular aspect. And, of course, it's important to really broaden the scope of the management modules that we have. But specifically because you represent, the Ministry of Tribal Affairs, I wanted to highlight one thing, that if the data that I have, if that is to be believed, the 8 states in India, they have 70% of the total burden of snakebite cases. And most of them are in the tribal districts, of course. So do you think that, can we do like a kind of tribal health cell that should come up, with the National Action Plan, sort of to prevent, control and manage the snake bites burden in India?
That we are doing it. We are on the job already. We are on the job to do the needful. And that's why I've said that we both are going to prepare a roadmap. And I'm saying the roadmap, the guidelines will be there very soon. And maybe the next year you will be able to see those guidelines in the field itself. And the training will be initiated. Actually, I am in another program also. There is a program of bone marrow, which is of blood disorder, is held at Apollo in the first. So I'm a chief.
Okay.
Go ahead with this also, because it's equally important, and I'm already working on it, the snake bite thing. And in the agenda of tribal affairs, there are certain agendas which has been taken up, and snake bite is one of them. So let me be thankful to my senior officials and the minister itself, because Arjun Munda said today itself, this is a good thing which you all have taken up. I told them you have taken up this issue. So because I'm supposed to inform everything, it's a good thing that everybody knows, and the current system over here. So when I told him they are also doing it, we also said go ahead with the things and try to make these training modules and as well the guidelines and the action plan as soon as possible.
Thank you so much, ma'am, for being here today.
For me. And it's a good learning for me as well, because I have heard from Honorable Governor as well, and from my leader. So I was very, when I heard he was DM Banda, my father was DIG Banda actually. I belongs to UP, and that is because I have been to, and I know the scenario and the demo very. You can always connect with us from the tribal, because I was at NHM, and he can always connect with us for the interiors in Sonbhadra and other villages which are important to him, districts. Sonbhadra, Mirjapur, where we I have gone through the data of UP as well, where we have much of the problems where we are having disease. So that has to be taken into account. Thank you so much.
Thank you so much, ma'am. And I think, first of all, I know despite your busy schedule, you were able to spare some time, for us, because that's the, that's how imperative this particular discussion is. And I think, thank you so much because of the broad, technicalities that you really brought into the, scope of the discussion today. It really set a very good context for us. And if you have, a few more minutes, I just have one question which could have come in the later stage of concluding remarks, but then, because there's a paucity of time at your end, I would just like to ask one thing, that given the relevance of this issue, right, do you think, and, of course, you highlighted many challenges, that we're facing today. Is there a scope to make snake bite, a notable disease in India? Because we have seen that, because reporting and data is a larger problem here with this particular, condition. Do you think, there is a way out, that there's a need for it to be a notifiable disease?
Notifiable is a big, it's an issue of discussion. Actually, I need to discuss with my senior officials, because being notifiable is not very important. You see, in my earlier, you must have known about that. I was looking after blood cell and I was taking care of thalassemia, sickle. There are no notifiable diseases, but we made it sure that it happens. So not necessary to have a notifiable disease, but the concern is we should take up it in a way where we are able to implement across the country and the things are taken care of. You're not necessary to have notifiable disease, but I still have a guts. My senior officials are pretty good, and my minister is also equally interested in it also. So we will be able to make a good roadmap which is going to implement it across the country. That is my concern.
Absolutely. And thank you so much for your inputs on this, because, yes, whether a notifiable disease or not, the efforts and the, that your particular ministry is really putting is really commendable. And, we really need that commitment for issues, which are more or less, more often than not are, neglected from the mainstream issues. So thank you so much, ma'am, for being here with us today. And we move on to Dr. Preetam Roy, who is the public health expert and a trainer for snakebite management protocol, and is also associated with the WHO India country office. So, Dr. Preetam, we saw that, we had people representing the policy side, and, we saw the commitment, we saw the intention of, realizing that, yes, this is a big problem area and something really needs to be done at the level of the government. But if we go back, we take little steps back and understand, particularly the disease burden of snakebite. What is the magnitude? What is the burden? And, data, because I think we saw a reflection of that pertinent point of data somewhere in the discussion until now, but we have really not reflected on it. So, if you could just, broadly tell us, what is the incidence and what are the issues with the data here for snake bites in India?
Yeah, thank you. Thank you so much. First of all, I would like to thank Integrated Health and Wellbeing Council for bringing this important topic here. Regarding the data that we have from the government side is from the National Health Profile Report. So the latest 2020, where we see that in 2018 and 2019, they have reported around 1.6 lakh snakebite cases. However, in 2019, they have reported around 3163 death due to snakebite, and which was very low in 2018, where just only 887 snakebite cases has been reported. So if we see that these snakebite deaths are substantially more among the males compared to females, and the highest reported was in 2019 from Odisha, which reported almost more than half of what has been reported pan-India. And from other states like Andhra Pradesh, Uttar Pradesh, West Bengal. But if we look at a broader level, the World Health Organization called for reducing the snakebite deaths and serious morbidity by 2030. So which requires a substantial progress in India. And for that, we need to have a strong database. So that's one very important. If we go by the literature review, so from the Indian million death study from 2001 to 2014, so the estimate leads to an average death of around 58,000 per year in India. So that's based on 2000 to 2019 data they have estimated. And so there is a need for proper capturing of the data. So we have a one national health profile report, but still we need to, I think, capture, because lots of cases and deaths go unreported. These are what we got in the health system reported in the government system. So there is a need for that. And if we see the profile of the burden, so at around from 30 to 69 years, half of the snakebite cases are occurring in that, and over a quarter in children less than 15 years. So that's one of the most important. Though mostly it occurs in home in the rural area, but in peri-urban area cases are also there. And what you also rightly mentioned, that around 70% of cases are occurring in the high burden states of 8 high burden states, and also spatially focused during the rainy season and at a low altitude. So that's important. And what we also find that if we say at the economically productive age group, less than 65 years, the chances of dying from snake bite from India is 1 into 250. So, so that's notably, and also that is notably higher in certain pockets where snake bite cases are occurring more. So that has a substantial burden in India, which must have to be dealt in a more integrated way and a more holistic way in capturing both the government and private sector. So that's what
absolutely, and I couldn't agree with you more on that, Dr. Preetham. While I do have a follow-up question from you, but then I want to bring in Dr. Soumyadeep also here, because we are talking about data. And Dr. Soumyadeep Bhaumik, he's the co-head of Meta Research and Evidence Synthesis Unit, the George Institute for Global Health India. So, Dr. Bhaumik, we are talking about data here because, as we know from the epidemiological side, from the public health side, data is a precursor, if any kind of, systems strengthening that we have to do. And here we are talking about policy as well, system strengthening, preventive measures, right? Data is a big question. So do you think, from your particular experience, I want to understand that, how can sort of we bridge these data gaps that we have? And, can the National Digital Health Mission, Health ID, can it be an enabler towards solving this problem?
Thank you. And I would just add on to what Dr. Preetham said and kind of look at more the solutions side of things.
Yeah.
And I think there's no one better than the National Health Mission to address this problem. Yeah. Data, as you know, has various aspects. One, of course, is the data which is required in terms of the epidemiology. That is the number of cases of snake bite, number of deaths happening, where it's happening, how it's happening. But there are also a lot of other types of data which we kind of never capture in our systems, especially around the morbidity of snake bite and the long-term chronic aspects of snake bite, which we never capture along. And we have done reviews and data of other countries, including very nearby in Sri Lanka and Bangladesh, where we see that post-traumatic stress disorders are seen in snake bite survivors with almost in half the patients who survive. So these data and these problems of the people are often not captured in the system at all. So I think the National Health Mission really needs to work on this. And often we talk about snake bite, we talk about the need for national surveys and things like that. But I think the solution lies in doing more localized survey, because what we sometimes call is the tyranny of the means. Which is that when we do a national survey, the numbers kind of get diluted in a lot of ways. Whereas if we have, and in our experiences, and maybe others who have worked more in communities will talk about it, in some villages and in some areas, They are the leading cause of death, much above than a lot of other things. And I think it's also important to understand and capture data around the equity side of things, like who are these people? These are rural and tribal people, often children, and often child. I mean, we don't see it as a problem, but they are often children working in farms of their parents, or even child laborers who are getting affected. And a single snake bite, even if it's not leading to that, has a lot of expenses that occurs. And I think the solutions, a lot of our solutions and the discussion around data is always around trying to understand how much venom is needed and things like that. But we also need to capture data which can help reorient it about towards prevention, like where is the bite happening, what are the risk factors of the bite, and these will be different in different places. So having more localized, probably block level surveys by identifying places. And we now have brilliant technologies in India, including GIS. A lot of people are working on it. So geotagging them and trying to figure out where these bites are happening, and like geolocating health services and primary health centers in a proper location so that maximum number of people can be reached. I think these are the things we should harness on, because India is a country known for its technological prowess, and there's no reason why we should not be using our prowess to do what is our problem in essence. And I would just add one more thing, is that I think it's our problem. It's very important for India to own our problem and start investing in it. It's good to have policies in place and things like that. But unless these investments are made in people, investments are made for survivors, and the government starts owning and developing and implementing this strategy with the involvement of a wide range of stakeholders at the state and as well as the local and the community levels, we kind of will never complete the data loop. Like the data gets captured, there's also need for the data to be fed back so that people can act on it. I think that's kind of the approach that might be helpful to strengthen our data systems.
Absolutely. Thank you so much, Dr. Soumyadeep. And I think you've really given a very comprehensive picture here. And I think until now, we were hearing a lot of policymakers talking about, some really significant, steps that are being taken at the policy level. But till the time, I think they are not matched with the data and the other things that you just mentioned, because you talked about the data spectrum that we really, not only we need to focus on the treatment side, but there's another side of, data collection, which is actually right now in whole vacuum, and that is really not being addressed right now. And how maybe, by highlighting the role of NHM that you said that, these things, these problems could be bridged. And I think, to you, Dr. Preetham, and to Dr. Bhaumik, I think we could, now if I can contextualize the whole data conversation that you both put in, and I think if I bring a coherence, and amalgamate this particular conversation with the policy developments at the government side. So from your understanding, and my question is directed at both of you, feel free to answer that, what do you think, given whatever both of you have just said, that what should be the priority of the government? Because in a way we have understood that, yes, government is, intending to do a lot of work in the space. So how can we prioritize certain aspects which are more important right now? So what are those areas?
Okay, I will go first.
Yeah, Dr. Soumyadeep, yes, we can go ahead with you.
And I think I would add on to what was being said before, like the priorities of course is prevention, because when we do prevention, we are saving all the costs which go downstream, and let us not kid ourselves into things. We are a lower middle income country, and we need to make our systems more cost efficient. So investing in prevention is really key. And I think a big priority which the NHM can do is NHM has the annual budgeting cycles. So even if a small amount of money is invested in doing localized surveys in areas which within a district, the
officials would know which are the areas of snake bite, doing that survey, identifying the risk factors, and then working with communities, community stakeholders to raise awareness on how these risk factors can be mitigated to prevent snake bites in the first place. In my opinion, I think these two should be the top two priorities which might be focused on. Of course, there are a lot of other things we should do in a health system. This alone wouldn't be sufficient, but probably this can be an approach that can be prioritized.
Absolutely, and I think we couldn't agree with you more on that. And here, I would like to bring in Dr. Preetham, and what would you like to add on to that? That what should be the priority areas right now for us?
So, as rightly mentioned by Dr. Shamadev, that these are our priorities, and adding to his previous comments, like not only collecting data for long-standing complications or follow-up, I think there are lots of complications like necrosis, chronic kidney disease, neuromuscular paralysis, then there are endocrine disorders, visual impairments, and most important, what he also rightly mentioned, is the psychological effects. So these long-term follow-up is also important, not only saving life, but then maintaining the quality of life. That is also important. So we need to have an integrated system where we can follow up this patient and deal with these long-standing complications. Apart from that, the identification of medically important species of snake, ecotypes at a local level, local surveys, which are very important, imparting trainings for the clinical diagnosis and use of antivenoms is important. But along with it, which I feel at the local level more important, along with not only giving the antivenom, also giving the supportive management for hemolytic, the complications that we are getting, and also for the neurological complications that are arising, the ventilatory support, the availability of atropine, neostigmine. So those are the things which will save additional lives, not only the antivenom. So this must be in our policy also, and also in the health system, that these medicines are, which are not very costly, but essentially life-saving. Few mechanism, few referral centers nearby, so that it should not take a long time to refer a patient for a ventilatory support or for a dialysis support. I mean, we save the life by giving the antivenom, but then saving another part is like the follow-up of all the complications that are already taken because of the venoms. So that setting up in nearby areas and having those facilities to deal with that adequate number of snakebite cases is also very important. And lastly, I would like to mention that inclusion in the curriculum of the medical students and nursing staff is very important. That is there, but if a more structured things comes in our curriculum, that will also help in dealing, because that's our medical, that saves the life. So with that, I said thank you.
If we trace, and I think I'm sure you are at a place, you're placed in a way that you have an exposure to another very sort of a very different kind of reality, to very subtly put, right? So in your opinion, if you could, start with, reflecting on the adequacy of the healthcare, infrastructure that we have, and what are the major challenges, in that particular segment from the patient perspective?
Okay. So first of all, I would like to thank Bharat Serum and IHW for putting together such an extremely influential panel to discuss this most neglected topic on snake bites. So coming to your question, we know that snake bite is a very common medical emergency in the rural India. And yet primary health centers in most cases are not equipped to stabilize, and then if need be, when the patient is critical, then refer to a higher hospital. So most of the times the patients are just referred, and there's a lot of time lag because of that. So the PHCs, the primary health centers, they do not even store antivenom. Very rarely, even if they have antivenom, they do not treat snakebite patients. In Bengal, I've seen many of the PHCs at least give the loading dose of antivenom before referring. But in most of the other states, the snakebite management at a primary level has a lot of room for improvement.
Yeah.
Now, let us look at what happens in the district hospitals, the rural hospitals that everyone was talking about. The referral cases are patients who have traveled anything between 10 kilometers to 150 kilometers to seek treatment. And due to too many referral cases for all kinds of ailments to seek treatment, the scenario in these hospitals is one of overcrowding and neglect. Many a times, due to non-availability of ICU beds and general wards operating at full capacity, critical patients are either turned away or admitted and assigned spaces below the hospital bed or in the corridors of the hospital. So snakebite is just one of the health emergencies in the rural setting. At any given point, a rural hospital is flooded with patients and their family members. So unless we start decentralizing treatments in local primary health centers, the quality of treatment and attention given to each snakebite patient will not change.
Absolutely.
So the priority must be to improve the PHC infrastructure and capacity building of medical staff. And every year, a special budget should be allocated to each district health office to improve and modernize the PHCs located in their jurisdiction.
Right. Absolutely. Thank you so much, Dr. Priyanka. And I think this is the right moment for me to bring in Ms. Urvashi Prasad who is the Director of Development Monitoring and Evaluation Office at Niti Aayog, because here we are talking about, decentralization, capacity building, and, Dr. Urvashi, do we have Dr. Urvashi with us here? I think she has dropped off. So, okay, I'll come back to you, Dr. Priyanka, for the same question that, yes, infrastructural development, decentralization, we need all of that. In a way, if we look at the Ayushman Bharat scheme, it already have certain elements of that particular aspect there. However, an infrastructural inclusion is what sort of, is a missing link there, right? While we might have certain provisions, certain things already existing, but an implementation may not be happening. So what would be your, take on that? Because it could be happening because of many other reasons, despite all the intentions and good intentions in place, to work towards this particular area. So yeah, your remarks on that. Dr. Priyanka, you're on mute. Could you please unmute yourself?
Sorry about that. So we have a lot of schemes and we have so many policies and all that. And from my perspective, even if we harness the existing policies that we have, we can do a lot. Ayushman Bharat also, there's just need for someone to be highly motivated to do such things. Like allocating budgets for primary health centers on a yearly basis. That's not something, in fact, maybe, because of the COVID situation, there's a lot of, PHCs, which, there was heavy lifting and ramp up being done in many of the districts. So we may have a better, state of affairs after the pandemic is over. I'm just hoping. But then, you not only Ayushman Bharat, let's look at, Swachh Bharat Abhiyan. Now that is something, it has huge budgets and there are so many things being done. But why not, why does snake bite happen? Especially, more than 50% of the bites happen inside your houses. So why does that happen? Because, there's the prey base, all that is more abundantly available in your houses, in your courtyards than in the fields. You look at fertilizer, people use fertilizers to grow crops. So all the insect, is killed. Now, what preys on insects are frogs and mice and lizards. That is the prey base of the snake. So ultimately, it's just an anecdotal observation, but, I have a feeling that, the snakes are moving away from, the agricultural land and all that, and actually going to places where there is, irresponsible dumping of garbage, for example.
Right.
So you have a lot of rodents there, and therefore you have snake bites also around that place. I have documented so many stories like that. Somebody went to dump garbage and got bitten by a snake.
Right.
So these are the things we can harness. That not just community cleanliness. It's not just going to clean your environment and make it beautiful and more hygienic and all that, but it's also going to save a life, from the perspective of snake bites.
Absolutely.
And snake bite is not an attack; it's actually a accident.
Right. Right.
So,
Thank you so much, Dr. Priyanka. And I'm sorry to jump in right now because of the paucity of time. We have to, bring in the next panel also. But, last but absolutely not the least, we have, an industry voice with us, a very significant voice, Mr. Vishwanath Swarup. Mr. Swarup, thanks for, being patient and waiting for your turn. And I know there is paucity of time right now, but I want to really hear one particular point from you that, everything that we have heard today, policy, infrastructure, everything that's on one side of the spectrum, and we have seen the commitment, right? But now, how do you think that industry can really contribute and bring a coherence to what is already happening,
Sure. So first of all, thanks to Kamal and IHW and Nalini for Dr. Nalini for organizing this. I think as Bharat Serum, we are committed to this space. We keep patients at the center of everything that we do. Be it this space or women's health, wherever we operate. And one of the things that we've realized, as it was talked about in the panel, prevention is better than cure any day, right? So how do you create awareness to make sure that people actually don't get this? But if they get this, how do you treat them? How do you get them the right access and availability? I think one of the key things that came up is very clearly, this has to be a notifiable disease. Because we're talking about one of the most vulnerable and population in their most productive ages being a target of this, right? And what we have seen very, very clearly is when, as a country, we put our minds together and put our might behind it, be it vaccination or be it the Swachh Bharat example which was given, we can make a difference. So if we come together, either from NHM or from state level, I think there's a huge movement that can start here. Now, so definitely a notifiable disease. Secondly, I would say is we are talking about treatment, but I think we need to also talk about the right treatment. Today, in most of our areas, we have a cocktail or a mixture or a formulation of venoms, antivenoms, right? How do we get, and the bites are not the same. We've talked about non-poisonous bites as well. But how do we develop a region-specific and the policy work required there to harness these venoms is absolutely imperative to start immediately. And I think here also we need a lot of support from the policymakers to help the industry actually come up with these solutions. These are very easy solutions that we can bring for the benefit of the patient. And this is something that I think we need a lot of help. But we are committed to this space. As the policy moves, we will be one of the first ones to actually deliver this to our patients. So with that, again, thank you all. In the paucity of time, I'm keeping it relatively short, but thanks to all of you for coming on this panel and also helping us think through some of the issues that we need to solve in this space. Thank you so much.
Absolutely. Thank you so much, Mr. Swarup, because I think everything that you've spoken about and understanding the important role of industry, I think intersectoral approach or a multi-sectoral approach in healthcare is, I think, we cannot more and more emphasize, there's no I think other way out, when it comes to intersectoral linkages within healthcare solutions and for health systems. So thank you so much. And a big congratulations to your, organization, which is really, so committed toward this particular, so-called neglected issue. And we have Dr. Priyanka with us. I think, ma'am, yes, you want to share some closing remarks. So please go ahead.
Dr. Vishwanath was talking about regional antivenom. So basically, there are two states which are already working on this particular, idea. One is West Bengal, where they have started, the Venom Collection Center. And there's another one happening in Gujarat. And I'm absolutely happy to introduce whoever is interested, to the relevant people.
Sure. We'll definitely connect on that. We are also working with the Rajasthan government on this. So we'll definitely connect, and as we can quickly move on this, it'll help bring a lot of respite to the patients. Thank you.
I think, and this is exactly what we meant by the intersectoral approach, is that, this is the, amalgamation of the, support and the solutions that we have can, really help us move forward. And while, we come to the close of the session here with us, this particular session today, but if there is any closing remark that I would like all our panelists to, come forward, and, if there is any closing remark that any one of you would like to share with us, please.
Dr.
Yes.
Nalini, may I
Yes,
speak?
yes, sir.
Okay, I would like to request one thing. We have got many problems discussed here in this webinar. So please make the list. Data collection is a problem, prevention is a problem, cure is a problem. Please make a list of the problems, and we should find out the solutions for these problems. That way we can move forward. So that is my request to you. You have noted down all the things during our discussion. And industry can play a very big role within very short inputs or investment. During this season, during this period, with the help of social media, if they should use awareness program through social media with a very meager investment, we can aware whole India, because that is a invisible topic. Snake bite is invisible. So industry under CSR can do this. So that is my request to the industry.
Dr. Lal, if I can jump in here, Dr. Kaushik, I think we'll definitely reach out to you. I think, in all fairness, UP is also my home state and very dear to my heart. We'll definitely reach out and see what we can work with you and your offices to drive this awareness.
And still we do have time, because the awareness day is tomorrow. So if you take the social media, some social media house, and they can aware for 1 week, Facebook or Twitter, you take the 1 week package and you give a 3-4 liners, it will aware too much, more than required. I hope so it will work.
We will do that.
And Dr. Kamal will help you a lot in this.
Absolutely. Thank you so much. Thank you so much, everyone, for being here, sparing your valuable time to discuss this particular topic. And with this, we come to the close of this first session on the invisible burden of snake bites on the health systems in India. And with this, we'll take a short break, and we will start with this panel 2 of this particular talk of this particular discussion, which is on snake bite, which is right treatment at right time. So thank you so much, and stay tuned.
Thank you. Thank you so much.
Thank you, everyone.
I think we already had a very rich discussions, and we have discussed about the public health issues related to the snake bite, and the different aspects of the prevention, creation of the awareness, as well as how we can address the problem with the right kind of treatment. This panel of discussion, where we have very esteemed, renowned uh, doctors, renowned public health experts, and the experts who are dedicated in the snake bite management, will be talking about, will be discussing about, will be addressing the issues related to the right treatment at right time. We have none other than, if I just take the name one by one, I'll start with Dr. uh, Sri Padmasri, Dr. Umesh Kumar Bharti, who is the state epidemiologist, State Institute of Health and Family Welfare, Department of Health and Family Welfare, Government of Himachal Pradesh. Welcome you, sir, in this panel discussion.
Thank you, sir.
Dr. Sadanand Rao, who is the consultant physician, MD in general medicine, and he is attached to a nursing home in Pune. But other than that, he has a huge contribution in the snake bite management in the district of Pune. Welcome, sir, Dr. Rao, in this panel discussion. Dr. Dayal Bandhu Majumdar, who is a senior, who himself has created a name in the eastern part of India and pan-India, I would say, in the snake bite management, the recording of the data, the information, and also regionalization of the anti-snake venom in the state of West Bengal. Dr. Majumdar is attached to Calcutta National Medical College, Calcutta. Welcome, Dr. Majumdar.
Namaste.
Thank you, sir. And from Bharat Serum and Vaccines, we have Dr. Alden Fernandez, Vice President in Research and Development of Biologicals, Bharat Serum and Vaccines Limited, Mumbai. Welcome, Dr. Alden Fernandez.
Hello, good afternoon.
With this, good afternoon. With this, we'll start the discussion, and privileged to start the way generally the medical panel discussion happen, starting with the understanding of the magnitude of the problem in India. In the previous panel, we have seen that we have a huge burden of the snake bite cases in India. We'd like to know from Dr. Umesh Bharti, sir, that what is the burden of snake bite in India? Why is the snake bite is still underreported in our country? And maybe I'll just add on to one more point here. Maybe in different setting, in the sentinel reporting system, in different parts of the country, can improve the availability of the epidemiological information on the snake bite. Over to you, sir. Dr. Bharti.
Thank you, sir. This is a very good question. You see, there are many studies being done sporadically to know the snake bite incidence and deaths and disability also. So there is no integrated data because snake bite is not a reportable disease. So though Government of India has asked people, the states to report snake bite through ASHA, through IDSP channel, but still that is not captured. So we have drafted a study with Dr. Menon and others. Many of doctors are here to know the burden of the snake bite in the pan-India on incidence, mortality, and economic burden. So that study has been sanctioned by the Government of India, and we are very soon going to start it. Because of the pandemic, it could not be started. So I think it is a guesswork that is being done. And until we have a snake bite as a reportable disease, till then we would not be knowing exactly how many snake bites are there, how many deaths are there, how many disabilities are there, and what is the economic cost to the people and the health system. So that is the need of the hour, that we should strengthen the system, make the IDSP and make snake bite reportable for everybody, from private clinicians to government sector. until that is done, we would not be knowing the exact data.
Yeah. Thank you so much for highlighting this point. And another aspect, when we are in the training in all the undergraduate college as well as in the postgraduate, is the lack of proper training in case of the snake bite management in particular. So my question to Dr. Raut is that, so how we can engage and teach or train the medical community in particular to treat the snake bite cases more intense way and more effectively to reduce the mortality as the morbidity related to the snake bite. Over to you, Dr. Raut. So you have to unmute yourself. So you are, yeah. Over to you.
I would like to mention very sad thing in this lecture today, that yesterday near Pune, one of doctor's daughter died due to cobra bite. She has not received any primary aid and she was referred to the tertiary hospital. So this is the situation in our country and developed district like Pune. So I was very sad. But many doctors, especially medical officers, they are reluctant to start KSV at a primary health center level, though it is available. They are fearing, there is fear of anaphylactic reaction, and they don't start, or if you start, they start 1 vial or 2 vial and refer patient immediately to the higher center. And many patients are coming in anaphylactic shock or in respiratory arrest, cardiac arrest. So they should be trained properly. And what happens? Every new appointment in a medical officer is totally untrained. He is not. He has just finished his internship and he is joining PSC for the purpose of just for finishing the bond. So he don't know anything to how to manage emergencies, how to do CPR, and there is no good infrastructure. Though there is no other ventilators or ambu bag or things available in the primary health centers. So in addition to having good equipments, they should be trained properly. And at the time of internship, they should be given training about the CPR during the internship period. That is most important, because they are just finishing rural internships and city internships for 6 months each, and they don't know how to manage emergency patients, especially snake bite patients. So they should be trained properly. They don't know proper doses of anti-snake venom, management of anaphylaxis, and CPR. So all these basic things should be given training to them immediately or before starting their practice. And in our area, what we have done, we are giving training to the medical officers of Jilla Parishad regularly, every 6 months or so. So where I am working in government hospital, all the medical officers and even community health officers, they are also able to manage snake bite emergency. So that is a good impact. So this should happen all over India, that they should get proper training in management of snake bite.
Right, sir. And I'll also take the opportunity, even though in very short, if you can just highlight, like, what is the first dose of anti-snake venom serum in case of a viper or a cobra bite? And how do we monitor the envenomation? And how do we decide the subsequent dose? So there are 3 questions actually. So you can take your time to explain this.
Yes.
Yeah.
In case of cobra bite and common crate bite, as everybody knows that both are the neurotoxic, and dose of anti-snake venom as per the WHO protocol and our national snake bite treatment protocol is during first hour we give 10 vials, and depending on the symptoms, neurological deterioration or improvement in the symptom, we give another 10 vials. So in case of cobra bite and crate bite, maximum 20 vials are allowed, and that they are beneficial. But sometimes there is recurrence of symptoms, maybe after 12 hours or 14 hours or 16 hours, and we have to give additional 5 vials or 10 vials depending on the symptoms, severity of the symptoms. So in case of cobra and crate bite, 20 vials are sufficient. In case of Brazil viper bite, we start with the 10 vials, depending on the whole blood clotting time and other parameters like hypotension and everything. And we repeat every 6 hourly whole blood clotting time, and depending on that we give additional 10 vials each 6 hourly. And if there is active bleeding, even after giving 10 vials, first 10 vials within 2 hours, 3 hours, then we repeat another 10 vials of anti-snake venom. Thus, in case of Russell's viper or Sausage viper white, maximum 30 to 40 vials are required. Maybe less than that. In sometimes 5 vials may be sufficient. So we decide on the whole blood clotting time, coagulation factors, if there is active bleeding or not, if there is hypotension, irregular pulse, and progression of the swelling. If swelling is progressing very fast, then we may give additional vials of anti-snake venom. And anti-snake venom should be the only treatment for snake bite. And we have to judge proper dose of anti-snake venom, because it is very costly and scarce. It is very rarely available in peripheral centers. So anti-snake venom is given in the proper doses and at a proper time, and whenever there is indication, proper indication is there. So this is about this thing. And many people are worried about the anaphylactic reactions to the anti-snake venom. So some people give adrenaline, prophylactic adrenaline 0.25 milligrams subcutaneously. But at our center, we are not using. We are observing patient very carefully after starting anti-snake venom. We watch for the yawning, cough, rash, early rash, and pulse, tachycardia, hypotension. If there is a difficulty in breathing, bronchospasm is there. Then immediately after first sign of anti-snake venom, we start give hydrocortisone 200 milligram and adrenaline 0.5 milligram intramuscularly. Absorption of adrenaline is given intramuscularly, absorption is good. So anaphylactic reaction is controlled immediately. So, and chlorpromethazine, like injection AVL and everything. So this is the treatment of anaphylactic reaction. There are 2 to 3 types of anaphylactic reactions. Early reactions, which are and late reactions, and serum sickness reactions. So the treatment is same for early and late reactions, but in serum sickness reactions, we have to give steroids orally and analgesics sometimes. So this is the treatment of anaphylactic reaction. And anything else?
So the A's that adverse reaction will come next. Actually, I have a dedicated question for you on that. Yeah, maybe you can elaborately describe that part. Now I'll come to Dr. Dayal Bandhu Majumdar. He has a rich experience of treating the snake bite cases for over last 25 years. Dr. Majumdar, my question is, like Dr. Raut has mentioned about the 20 minutes whole blood clotting test. So what is the accuracy and reliability of the test to detect the hematotoxicity along with the other tests like, the P time or INR or fibrinogen? And the second question I'll be asking you after you finish this is about, does the ASV work in great bite after the patient has come to the hospital with a form of neurotoxicity setting in? Dr. Majumdar.
I would like to answer your second question first. Definitely, it works. Most of the time, we get the patients of great bite with bilateral ptosis, and they come to us after 6 or 8 hours, like that. And in almost all the cases, 100% of the cases, antivenom works. Antivenom works. Whenever you give, antivenom works. But if the patient goes to respiratory failure, we have to give him mechanical ventilation. But antivenom works anytime. For detection of viper bite by coagulation test, your first question, 20 WBCT is worldwide accepted test. 20 WBCT is a bedside test, and it can be done in a primary health center also. And it's not any theoretical comment from me. Hundreds of our primary health center doctors are doing it regularly. It's a very simple test and anybody can do it. Even our trained sisters are doing it in the primary health centers. 20 WBCT is a very accurate test, and if 20 WBCT is not clotting, 100% sure that it's a viper bite. But if you can train your doctors, if your doctor is trained, in most of the cases, 20 WBCT is not needed at all. They can clinically diagnose it to be a case of viper bite. I would like to tell for 1 minute on training. In West Bengal, we have a very, very systematic training system. Actually, in 2012, we are funded by then National Rural Health Mission. Later on, it has been converted to National Health Mission. National Rural Health Mission funded our training system. We had printed 8,000 module books, snakebite training modules for medical officers. We have trained more than 8,000 medical officers. Classroom training. First of all, we have made some trainers from all the 18 districts of West Bengal. We have taken 36 doctors, dedicated doctors who are ready to give training to their candidates in their own district. And then I have traveled to almost all 18 districts. We have arranged for a batch of 20-25 doctors in the district hospitals, in the subdivision hospitals, even in the rural hospitals also. Give training to the rural doctors, and that will do miracle. In West Bengal, almost 100% of the snake bites cases are given the primary treatment in the primary health center only. Nobody will refer a case to a higher center without a loading dose. Each and every medical officer in our rural health centers are trained to give 100 ml of antivenom to a venomous bite, then only they can refer. Now, in the pandemic situation, I have taken almost 10 to 12 classes, online classes. Actually, I have discovered this opportunity of Zoom and Google Meet. It's a miracle to us. Nowadays, the district authorities are arranging training for their district doctors, and I am sitting at home and I am giving training to the rural doctors. They are sitting at their home, and we can arrange it even in the evening times, in the leisure time of the doctors, and that is more practical. Arrange for training of the doctors first. Give training to the doctors, they will be motivated. Because our MBBS curriculum is faulty. Nobody is trained for snakebite training in our MBBS colleges. That's why our doctors are not confident. Give them training. Give training to the rural doctors, and they will do everything.
Thank you so much. And that leads to the question to Dr. Bharti. You are attached to one of the institute as well as you are running a department. So how we can improve to enhance the importance of the snakebite management, which are very practical, to improve the overall training for our medical curriculum?
Yeah, thank you for this question. When I joined the institute, then we knew that doctors, when newly appointed doctors are given induction training, so there was no lecture on snakebite training. So I introduced snakebite training lecture for 1.5 hours, and since I joined, we have trained around, I think, more than 500 doctors who were newly appointed. And not only we have trained the doctors, we have made a IC material to tell them, to show them which are the venomous snakes of Himachal Pradesh, which are the non-venomous snakes of Himachal Pradesh, because even doctors are not aware, except cobra, they don't know what other snakes are there and which are venomous snakes, which are non-venomous snakes. So they are taught properly about the snakes of Himachal, and not only about the snakes of Himachal, how to treat them and how to take help of transportation 108. That also we are the second state in India that has that has ASV in the ambulance. So as soon as the first aid is given, ambulance is called, and paramedics in ambulance, sometimes in need they give ASB to the. But still there is I have not seen a reaction for the last so many years. But when we give this anti-snake venom, sometimes there is immediate hypersensitivity. So I think to blame doctors that they fear that the reaction would be there, I think that is also wrong. We need to purify at a global level the anti-snake venom so that reactions are minimum and doctors are confident to treat.
You have raised a very good point, and my question is to Alden Fernandez, because since you have raised a point related to the manufacturing process and purification. So Dr. Alden was quietly listening for quite some time, and my question: is there any new changes which has happened over last 10 years in the manufacturing process to reduce the overall anaphylactic reactions or any reaction parts when it comes to AS-based therapy?
That's a nice question raised by Dr. Bharati. Actually, see, this is a very old product. When I say old, the initial work on antivenoms was done in 1890s, and subsequently Hafkin and all were the first ones to develop these products. Since then, till the 70s, there was hardly any work done, and ammonium sulfate was regularly used. Now, in ammonium sulfate precipitation, what happens is your immunoglobulins, they go into precipitation mode. So when you precipitate a protein, it loses its original structure, and then bringing it back again into the structure is very difficult. So this causes aggregation of the proteins, and then you can cause huge reactions in the patient. So there was a paper published somewhere in 1950s by Steenbuch and Audran for human immunoglobulins for caprylic acid precipitation. But until 1998, no work was done on any of the immunoglobulins, neither human or equine. So in 98, there were some research publications which came in from South America, where they were trying to work on small scale purification of caprylic acid precipitation of immunoglobulins. We were the first ones in India to launch the product with caprylic acid precipitation in 1999. Since then, there have been multiple changes which we have implemented to ensure the product is of the best grade. In fact, the product which is prepared now is even better than some of the human immunoglobulin products which are made. So one thing to start with is you have caprylic acid precipitation. Before that, you have a digestion to get rid of the FC arm. So you only have the Fab-2 molecule. Then you have the caprylic acid precipitation, ensuring all the other proteins and impurities go into the precipitation, whereas your Fab-2 remains in a liquid part. Then you separate the liquid part, so it is intact Fab-2, which is not damaged. You load it onto column chromatography, ion exchange chromatography. This will further polish your product. And this was implemented somewhere in 2010. There is a paper also which we published on this. You pass it through the column chromatography in ion exchange mode, in a flow-through mode. Again, there you do not allow your Fab-2 to bind onto the column and then elute it, so that you don't have any, the interaction with the column material, and then you use harsher chemicals to elute it out. All those are not there. So you allow it in the flow-through mode. All your impurities end up binding onto the column, and you have a very highly purified product. In fact, we have gone one more step ahead, and we are working on nanofiltration to ensure that the viruses which are there is an enhanced safety level which is there for the equine immunoglobulins.
Thank you.
Dr. Saswata?
So let me, in the meantime, ask you whether other companies have also started the caprylic acid purification, or still they are in the pipeline?
Sir, as far as I know, at least 2 of the other companies have started with caprylic acid purification in the last 5 years, and 1 or 2 companies are still working on ammonium sulfate. But other than caprylic acid purification, there are many other things which cause allergic reactions in the patients. So this could be because of one is aggregates, the second is endotoxins, you have albumin, you have a host of other equine proteins which are there. So if these are there, and you can elicit a good IgE mediated or a non-IgE mediated reaction in the patients, and as a result you will get a good set of anaphylactic reactions in the patients. So it has to be a comprehensive overall approach for purification of the product.
So WHO is now going for pre-qualification processes for ASB. So
Yes.
are you planning to apply to WHO pre-qualification?
Yes, last year we had a meeting, in 2019 we had a meeting with the WHO. This was held in Thailand for the WHO pre-qualification, and we were a party to it. We've already discussed with them. In fact, this week they had another meeting on snakebite awareness and how to go ahead with the antivenom scenario, especially in Asian region. So hopefully they will come up with the timelines. Actually, the entire thing was delayed probably because of the COVID situation, but in a year or so we should have pre-qualification and all restart.
So by the time he comes, I am the host. Suppose there are many studies that shows.
Yeah. So I have come back, sir.
Oh, you have come. Let me complete my question.
Yeah, sir. Please go ahead with your question.
The gap for you.
No. That's perfectly all right.
Many studies. There are many studies that shows, like Karthik Sunagar and other Anita Malhotra and other many people have done studies in India. They have shown that even around with any of the anti-snake venom, 40% of venom does not neutralize the actual snake venom. Actual snake venom were titrated against the anti-venom available, and 40% of them was not neutralizing any of the venoms, neither cobra venom, neither crate venom, neither Russell Viper. So, do you think that there also you need to strengthen your system of making foolproof anti venom?
Sir, one major thing is if you look at the efficacy, one thing is India is actually a very diverse country. And there have been several publications from Karthik's team, Rom's team, Vishal, and everybody. So the snake species, there is a lot of intraspecificity and interspecificity. Now, we have only one major source of venoms which is coming from Kerala, and that is Tamil Nadu. So, and there are sporadic, some small manufacturers in Uttar Pradesh and all. But what happens is when you take these venoms from one particular location and you try and generate an antivenom, so there is a chance that you may require higher amount of vials in certain regions. So you need more of these antivenom, venom banks or serpentariums to come up from different regions of India. Till then, we are already in discussion, in fact, with various state governments. I think Priyanka mentioned about Gujarat and Vishy mentioned about Rajasthan. We would also like to work together with the West Bengal government, in fact, and try and get the venoms from all these regions and to see if there is a regional antivenom. I think that is the need of the hour. Otherwise, if you look at it, even in the WHO, as it mentions, there's a huge range of variation. You will have a species variation, you'll have a genus variation, you'll have the small snakes, the young snakes, the juvenile, the male, the females, the subadult snakes. There's so much variation. So to capture all these, you need venom from various sources.
Yeah, true.
I think Dr. Majumdar has a point to make. Yeah.
Actually, West Bengal Forest Department has already given permission to a private company on 29th June, to set up a serpentarium in West Bengal. Actually, we are fighting for that for last 4 years. At last, on 29th June, the Forest Department has written to the Health Department that we are giving permission to set up a serpentarium to the Manusa Biotech.
That's nice to hear, Dr. Majumdar. I think I'll connect with you offline. We could talk about this and take this forward. That's some good news.
Actually, Priyanka Kadam is in contact with all of them.
Okay. Great. Nice to hear that, sir.
Okay. So now back to the core part of the treatment and the right treatment at the right time. I'll come to Dr. Raut related to, the apart from, the core area of the snakebite related complications. So one of the big thing is, the renal failure. And so how, that we should go ahead, such cases of renal failure and other, you have covered the anaphylactic reactions. So and other adverse event related to the snakebite, if you can throw some light on that.
In case of Russell's viper bite, can you hear me?
Yeah, we can. Yeah, please.
In case of Russell's viper bite, there are chances of renal failure. So if we start anti-snake venom as early as possible and given in proper doses, and if there is a shock management and proper hydration of the patient, chances of renal failure are very less. Last year we had seen around 100 patients of Russell's viper bite. Out of them, 92 came directly within hour or 2 hours, and treatment is given, and none of them has a renal failure. 8 patients who presented late, around after 8 to 12 hours, all had a renal failure, and some of them required hemodialysis also. So immediate prompt treatment is very important to prevent renal failure in case of Russell swiper bite. Proper doses and hydration. These are the things. And if there is a renal failure, then we have to start monitoring the patient very closely. We have to put a central line, CVP line, and then monitor intake output charts, pulse, blood pressure, and oxygen saturation, and daily renal function tests. So these are the important functions. And as soon as we notice that there is urine output is decreased and renal functions are increasing, that is urea creatinine is increasing, we have to give him fast hydration therapy, that is and give Lasix also. So if CVP is very low, so we have to correct the CVP and then we have to give Lasix. So if these things are okay, that is we are doing forced alkaline diuresis for the early ARF patients. If renal function is not improving and urine output not is increasing and creatinine is going around 8 or more, then we give him a dialysis. We are doing also blood glasses. If there is acidosis, we have to correct it. And some patients may require around 2 dialysis, 3-4 dialysis, and some may require, I have seen patients who require 20 dialysis. 1 or 2 patients who presented very late, they required dialysis for a long time. That is almost chronic renal failure. So this is the situation. So simple thing is that early and proper doses of anti-snake venom, correction of hydration, proper hydration, sometimes maybe over-hydration, and close monitoring of blood pressure, pulse, and immediate treatment of shock. These are the best remedies to prevent renal failure in case of Russell swiper bite.
Dr. Majumdar, another aspect is the altered coagulation. So, any role of fresh frozen plasma in reversing the coagulation?
Yeah, actually, in our national guideline also, we have mentioned that maximum 30 vials can be tried to bring the coagulation defect in track. If 30 vials is not working, then that antivenom is not working. And try fresh frozen plasma. Fresh frozen plasma has a good role.
Okay. Very right. And another area is, in case of the neurotoxicity, what about the role of atropine and neostigmine in case of, crate or cobra neurotoxicity?
In case of cobra bite, atropine and neostigmine definitely helps, but it is not useful in case of crate bite. We give injection atropine 1 cc and neostigmine 1 cc IV and repeat it 1 hourly, maximum 3 doses only. And depending on the neurological symptoms like whether ptosis improves or not, that we decide the doses. Sometimes 1 dose is also sufficient, but maximum 3 doses we are giving atropine and neostigmine.
Actually, regarding atropine and neostigmine, I say to my juniors that an injection is life-saving. We say an injection, atropine first, then neostigmine. Actually, if you get the cobra bite patients in late stage, first of all, give an injection, atropine and neostigmine, then start antivenom. The atropine neostigmine injection will prevent respiratory failure. The antivenom will work slowly, but atropine neostigmine will reverse the neurological blockage. But in crate bite, there will be no difference. And I have seen in the ICU of a medical college also, after 3 days of crate bite, as there is ptosis, the senior consultants, the visiting physicians are advising more atropine and neostigmine and more antivenom. Actually, there is no role. The ptosis in case of crate bite, it will persist for 3 to 5 days. Actually, in our WhatsApp group, we are in consensus with the use of calcium gluconate. It will be beneficial in case of crate bite, though there is no publication yet, but In our WhatsApp group, in last 5 years, we have got hundreds of cases of benefit from calcium gluconate injection. Our juniors are trying calcium gluconate IV 3 times a day, and the mitosis is reversing earlier, in case of crate bite.
We are also using calcium gluconate every 8 hourly in case of crate bite.
Right, right. And you know that any upper limit of repetition of the calcium gluconate, like some signs or that should be looked by the resident.
No, it should be a 10 ml 8 hourly. That is, there is no specific doses for that. But we are trying with 10 ml 8 hourly.
All right. Okay. Okay. Now, one more aspect before I move to the how we can generate more data on the snake bite related deaths or the research going forward. One question to Dr. Alden. So, what are the problems in getting venom, generating the antibodies in horses, donkeys, mules, or camels, and also getting the ASB? And how do we actually ensure the efficacy and efficiency?
Yeah, I think partly, Dr. Saswata, when you were offline, we discussed about the venoms and variability. So, to talk about how an antivenom is made, there are various species which have been used. One is equine species, camelid species, ovine species, and chicken have been, they've tried working on this. And in equines, in India itself, horses, ponies, mules, donkeys, all these animals have been tried and tested. In camelid species, ipacas and camels have been tried. And ovine species, basically goats and sheep. Sheep, they have been successful. In fact, there are products from Protherix and Microfarm which are being sold in UK and in US. But then you have the question of PSC, BSC and all these diseases which are coming from the ovine species. Chicken have not been successful commercially until now. So equine has been the mainstay for the last century almost. One reason why they have been successful is they tolerate very high doses of venom. It is easy to harvest blood from them on a large scale from these animals based on their body weight. So it's a tried and tested method for more than a century. Easier availability of ponies in India. So they are easy to handle and harvest the blood. Antibody profile is known. You have well established purification methods. Now the challenges is maintaining the horse farms, maintaining all the rules and regulations around that. The long gestation period for generating these antibodies, it takes close to almost around 6 to 8 months to generate antibodies. Then on the efficacy and efficiency part, the horses are now immunized actually with a cocktail of the big 4 venoms. As per the Indian pharmacopoeia, because we have a polyvalent of big 4, so which constitutes both the elapids and the viperids, and they are tested as per preclinically tested as per a bioassay. It's a murine lethality model known as a ED50, wherein you have a fixed dose of venom concentration and you vary the dose of the antibody concentration, and you see the susceptibility around it for a period of around 48 hours. This test basically what it does is it identifies the toxins, whether they are neutralized in an animal model, and these venoms, the control venoms and all, are given by CDTL Kasoli for this. Prior to the testing, in fact, the venoms are tested for one of the tests, which is lethality, which is an LD50 test, which is conducted. So these are the issues with respect to how the whole antivenom is generated in animals, the efficacy and the efficiency. Yes, we do have challenges like I discussed earlier in getting regional venoms, and because there is only one region of India where we are getting the venoms from. And we are working with various state governments, the forest department, to try and get a better venom bank. And if that is made possible, I'm sure we should be able to have a pan-Indian with a bigger approach and bigger reach antivenom.
Right. And then that leads to another question, related to the safety, especially during, the outbreak or the zoonotic outbreak. So how these antivenoms are, safe in terms of the manufacturing process from this zoonotic outbreak? If you just highlight a little bit on that.
Yeah, Actually, as you know, in fact, if you look at it right from the 90s, there have been various diseases which have come from zoonosis. So one is your BSc, TSC, then you had your Hendra, Nipah, SARS, H5N1, Ebola, Zika, and now the COVID-19. And as a result, you have to be really careful when using animal-derived or human-derived biological products. And this can be a biosecurity hazard for people who are taking the products or people who are coming in contact with animals. So it shouldn't be a single, as per the EMEA guidelines for any of the biological products, it has to be almost three complementary approaches, principal complementary approaches need to be taken. So from the start, it would be donor animal screening. So you physiologically check each and every aspect of the animal, the status of the animal, the history of the animal to check how the animal is doing, and whether the earlier generation of these animals had any infections or carryovers or anything. Then you characterize your source material. What is your source material? Your source material of animal origin would be pepsin, which is used for digestion, or you would have the animals itself, like the sheep or the horses. So in this case, what manufacturers normally do is they test these animals for various disease markers, and what we do is we test them by PCR to ensure that none of them are active carriers, rather than just checking for antibody response in these animals. Another thing is to incorporate specific steps which are there in the manufacturing process, which help in either removal or inactivation of the viruses. So these steps basically have the ability to either inactivate or remove the viruses. So when I say inactivate, you can have pH extremes and enzymes such as pepsin and chrysols, which are used as preservative. These chemical inactivation agents, what they do is you have lipid enveloped viruses, and these can disrupt the lipid membranes, or you have the removal also which is caused by precipitants like caprylic acid, which Dr. Bharati was mentioning. So at very small concentrations also, caprylic acid disrupts the lipid envelope, and you can remove a whole lot of almost 4 to 5 logs of viruses. Then finally, we do a polishing step, which is ion exchange chromatography. And in this, what you do is you allow the product to flow through, and all your impurities end up binding onto the resin. It's an ion exchange model. So as a result, there again, you have another stage of purification. All these stages of purification help in enhancing the product quality. So another thing is control of the animals. So when the animals enter into the farm, normally these animals are quarantined for a period of 21 days. They are not taken into the herd directly. They are checked for all these various, your liver function test, kidney function test, your hemat profile, your deworming is done, blood stool testing to see if there are any parasites which they are carrying. Only animals which are selected are then transferred into the main stables where they can be taken up for production. Even on a regular basis, in fact, the feed, the water, all that is checked for pathological bioburden for Salmonella, Pseudomonas, E. coli, to ensure that none of the animals are infected during the manufacturing. And then you have finally the manufacturing facility, state-of-the-art manufacturing facilities where we have water systems which are of injectable grade, antigen, and the manufacturing is done under Class A conditions. You have bleeding, separation of plasma, which is done under laminar air flows. You have clean room, CGMP facility for all your activities. And finally, in the manufacturing of the product, you have stage-wise, so many tests are conducted at every stage to ensure the purity and the quality of the product. In fact, at the end stage, there are 18 tests before the release of an antivenom batch.
So on a lighter note, these animals are living in the way human cannot even think about it. Right. So we have almost come to the end of our discussion. So another very important point for for all the medical practitioners, now that we have entered in the era of evidence-based practice. Now my question straight to Dr. Umesh Bharti, like how can we generate or conduct an evidence-based, well-designed clinical trial to manage these snakebite cases more based on the data, based on the evidence?
See, I would say one line answer is the funding support, because many scientists and even me, I am also ready to do so many trials. So we don't have funds, especially for snake bite. There are no funds at all. It's similar like in rabies. So I think instead of hosting conferences, let us host research. Let us float. Companies can float research interest. Sort of tenders or so that people come forward and for the research, and because of the positive, even companies can lead the research. There is no harm. Like you have seen now in COVID vaccines, companies have led the research. Almost all research has been led by the companies. So my request would be, let us not waste money on hosting conferences. Let us waste money, let's use money rather on supporting researchers, so that they do the best of the research along with the companies. We don't have anything. We are not separate to the companies. So let us jointly do something. We know the people who are there are very few, 50, 100 people I think, who are prominent researchers in the country. So they can be identified, and a pan-India research protocol can be made, and I think not only for existing antivenoms, but new technology of antivenoms like phage typing and monoclonal antibodies. So there can be so many things that can be done. So I think industry has to take a lead, because we don't find funds anywhere, and without funds, it's very difficult to do the research, to hire people, to do the testing and have lab support. So I think you people have to take a call on this.
Dr. Majumdar, your opinion on this?
Actually, snake bite is a life-saving emergency, In true sense, it's very difficult to do a randomized control trial on snake bite management. Snake bite management, you cannot do a randomized control trial. Actually, the treatment policy available in India is not bad, it's almost 100% foolproof. The problem is being created in two steps. Primarily, the treating doctors are not well trained. Primary bottleneck, that in medical colleges, snakebite treatment management is not trained. And second one, which Dr. Eldon was telling, the availability of a pan-Indian antivenom. Actually, regional venom collection is the key factor for pan-Indian antivenom. I can see Priyanka Kadam has joined here now, and she will highlight the availability of these regional venom centers. If you allow Priyanka Kadam to say something.
She is there. Yeah. You can just switch on your video, and or it's all right. You can also go ahead with the audio only.
Yeah. So basically, I had spoken about the two centers where this project has been undertaken. One is in Bengal and the other one is in Gujarat. So I'm a part of the Gujarat project, and that also, because of the pandemic, the things have slowed down. But definitely in this year we will, start with a small team over there in Valsad.
Great. And Dr. Eldon has said that he will definitely connect with you related to that project.
Dr. Eldon and myself, we are friends for a long time now. So.
Yeah, I know. Yeah. Fine. So we have come to the end of almost this enriching panel discussion for last 3 hours we are having. So I'll go back to the panelists. Just maybe one liner from all of you related to that what according to you is probably, in your opinion, only one thing if we do right, we can save life and reduce the mortality. So I'll start with Dr. Raut, and I'll go back to all the panelists. After Dr. Raut, we can start. So only one point, if you just say.
Snake bite is a fatal accident, and immediate and prompt treatment with anti-snake venom can save the life of the snake bite victims.
Thank you, sir. Dr. Bharti.
Yeah, I think awareness.
Only one point.
Awareness is a key, not only for communities but for doctors and for everybody. That's very essential. That would I would say.
Thank you so much. And Dr. Majumdar.
What I was telling in my last session, the training of the doctors, training of the doctors, and my training is like, the motivation gurus, what these gurus with beards and mustaches say. I do motivate more my juniors to treat snakebite cases at your center, motivate them, and they will save thousands of lives, which our rural doctors in West Bengal are doing for last 7-8 years.
Thank you, Dr. Majumdar. Dr. Alden.
Yeah, I think one major thing which we have to look at is coming together from various states, setting up snake farms or serpentariums. We have a better mix of venoms which can make the product pan-Indian as compared to having one snake farm from a particular region of India. So when we make a better antidote which has a broad range effect, it definitely makes the quality of life becomes much better for the patient.
Okay, so thank you. The key take homes are there. So first, awareness. Second, act fast. Third, motivate to treat better with a good training. And fourth, the best of available options, and have the diversified mix of the anti-snake venom therapy. Thank you so much, and hope that you have all enjoyed, and share your comment and give your feedback in the Facebook page as well as in the Twitter. My sincere thanks to all the panelists for being here and enrich for these enriching discussions.
Thank you.
Thank you so much, Dr. Safra and IHW for organizing this.